Doing a primary PCI in STEMI patient is one absolute way of saving a patient's life. If you ever think as healthcare professionals, how can you save a life? That is the way to do it. And there is nothing more rewarding than that. So thank you, Dr. Konopalli, for sharing that. I'm going to talk about stents. Or as Dr. Ramchandani, our surgeon, says, I do stunts, not stents, but we'll talk about stents. So just going back historically, the first heart catheter was done all the way in 1929s, where a radiologist basically ran a catheter up his antecubital fossa to the right side of his heart, did not die, and then, oh, maybe we should be able to do this and survive. Dr. Sones up in New York in the 1950s was doing actually an aortic root angiogram, and the catheter dropped into the RCA, patient fibrillated, but patient lived. And they said, well, maybe we can do coronary angiograms actually. Dr. Grunzig is the father of interventional cardiology. He was from Germany, and he was the first guy in 1974 who presented an abstract in American Heart Association doing a balloon angioplasty in the leg artery. He was brave, along with a couple of our American colleagues, in 1977 to do the first balloon angioplasty called PTCA in 1977. Now imagine this. This is hard. You're trying to put a balloon, push it to 10, 12 atmospheric pressure, and hope that the artery does not tear. In those days, these are brave steps. And because all we did was bypass surgery on patients in those days. So 1990s, the stents came along. And obviously in 2000, the biggest revolution just kind of saved my field and made it stronger than ever is drug-coated stents. So we'll talk a little bit about that. This is a typical cath lab. I don't know if many of you have seen one of our cath labs. And so that's me in the blue gown, but we would have a scrub nurse. We would have a vascular tech, and we would actually have two more nurses. One will be charting the records, and one will be administering medications. Patients are awake, we give them a little bit of sedation, and then once we identify a blockage, we start with stenting that vessel. But before we get to the stent, I want you guys to kind of understand the basic principle, how it is done, because one of the commonest questions I get asked is, well, hold on, what happens to that plaque? What happens to the cholesterol buildup? This is what happens. If you look at it carefully, you actually bring a wire and then a balloon, and if this is your cholesterol buildup, this is a cross section. You can see the balloon cross section and the fatty plaque on the right side. We basically, when we go up with the balloon, the plaque gets pushed out. It literally gets compressed, and when you kind of take that balloon down, the vessel remains open in that sense where there's compression of plaque. And this is a very important concept, because if you're a plumber and if you got a fixed pipe, you can't do this. The human artery stretches, and that is a very basic principle why we are able to do something so simplistic in an idea, that we can actually stretch the human artery, push the plaque out of the way, and you maintain a lumen for the blood to flow. So balloon angioplasty, as I said in the early days, was a scary thing to do. I mean, we would balloon open that artery, and 4 to 8% of them would have abrupt closure. They will just shut down in front of your own eyes, and almost 1 out of 5 patients had to be rushed down to emergency bypass surgery. But even if people who survived, well, vast majority of them had restenosis. So what is restenosis? So let's follow this diagram. So the first one, the yellow is your plaque, cholesterol buildup, and that's your lumen. So you can see a narrowing. You do a POBA, which is also, by the way, you guys may come across this term, POBA, plain old balloon angioplasty. We are not very creative, but that's what it is. And after doing a POBA, we open up the vessel. There's a little bit of recoil because as you deflate the balloon, some of the vessel comes down. But what was really frustrating is actually this neo-intimal formation. You know, once we put in a balloon angioplasty or do a stent, we are hurting the vessel. We are actually stretching the vessel. We are doing a mechanical instrumentation of the vessel. It reacts with scar tissue buildup, and that is what we see. So when we started doing bare metal stents, we did not have that abrupt closure. Even after putting a stent, the recoil was very minimal, so the vessels look pretty good. However, at 6 months, a lot of scar tissue would come back. So in the 1990s, we struggled with this idea about people coming back to the cath lab. Almost 3 out of 10 patients would come back to the cath lab because of scar tissue buildup. Well, that kind of all got better once we got drug-eluting stent. So again, the same principles apply. You put in a stent, There's minimal recoil. But what is the beauty of drug-eluting stent, and that's what we're going to talk about in the next 10 minutes, is because it allows for the scar tissue proliferation to be inhibited. So you don't get scar tissue buildup. So what are the indications? Acute STEMI, as Dr. Kunapali talked about, non-elevation MI, unstable angina. Stable angina, patients are walking around but says, Doc, I hurt in my chest, and you had an angiogram and you find a blockage. Does that patient qualify, or can we do medical therapy? There was a trial called Courage, to have Courage trial, basically showed there was no difference in outcome, and you can actually follow those patients with medical therapy. Obviously, anginal equivalent dyspnea, arrhythmia, high-risk stress findings, like as Dr. Quinones told us in the morning, if you have more than 15 or 20% defect, those are high predictive of cardiovascular events. In an asymptomatic or mildly symptomatic patient, because these are actually very common patients. A lot of our 56-year-olds say, well, yeah, I'm getting a little chest pain, a little shortness of breath. What do we do? Well, there has to be objective evidence of moderate to large amount of viable myocardium or moderate to severe ischemia on non-invasive testing as an indication. So that patient has to have a very abnormal stress test for us to take on those patients. We strongly believe in a heart team approach where we discuss cases with our surgeons, and that really allows us to optimize, especially in complex patients with diabetes and multivessel disease. Contraindications. I guess there are none. Oh, no, hold on. There are some. I'm biased, I guess. So related to clinical, one is intolerance or inability to take long-term antiplatelets, presence of any significant comorbid conditions that severely limit the lifespan of the patient. Chronic kidney disease is kind of scares us interventionalists because dye injection will try to help their heart, will end up hurting their kidneys. There are some angiographic contraindications relative. Very small arteries, obviously. The smallest stent we have is 2.25 millimeter. Remember, the typical coronary artery is about 3 millimeters. So it can range from 2.5 to 4 millimeters. But anything which is very small, diffusely disease vein grafts which are old, more than 7 years old, they crumble. They're like old pipe, and they just crumble the minute we touch it. Another coronary anatomy, which is very calcified, very tortuous vessels, which are very difficult for us because there are complications. So not everybody should be undergoing PCIs without a thoughtful evaluation. MI death and stroke is about 0.1%. Excess site complications about 2 to 3%. If you go femoral, which is the vast majority, at least in the US right now, there is about a bleeding risk of about 2%. If you go radial, obviously you have almost no bleeding risk. Non-excess site bleeding is a big deal because whenever you do PCI, patients are on antiplatelets and medications, so GI bleeding is fairly common. CIN is contrast-induced nephropathy, about 2%, allergic reaction, radiation exposure, perforation, and stent thrombosis. I want you guys to think like engineers, biomedical engineers, because to really understand this field, one has to understand how a stent is designed. There's a metal, there's a drug, and there is a polymer. Polymer is required for us to put the drug on the stent because you can't just attach a drug molecule to the metallic stent without a polymer. Polymer is a carrier. So there are varieties of stents. The ones in the greens are the ones which are latest nowadays. So I'm not going to go into the details, but I can tell you from stainless steel, we have gotten into platinum, chromium, cobalt, chromium. Our strut thickness, it's getting thinner and thinner. So we are down to 80 microns. The polymer thickness is smaller. Sirolimus, these are the group of drugs we use, and so on and so forth. So there has been a lot of advances. So for example, because of these advances, their failure rates have gone down to almost 1 or 2%. So has the emergency bypass surgery gone down to 1%. Restenosis, which as I said was a big problem, has substantially reduced ever since we got drug-eluting stent. Stent thrombosis rates are very low, as well as very late stent thrombosis are extremely, extremely low. So at about 1 year, what do you expect? One of your patients has gone through a drug-eluting stent. One of your family members has gone through a drug-eluting stent. What do you expect? We expect that at 1 year, at about 12 months, there's going to be 8% target lesion failure. So there is a reason that patient may require another stent procedure done, or may end up having an MI. And that is still very acceptable. That basically means that 92 to 94% of the patients do just fine. However, there's a catch-up phenomenon. Catch-up where when you follow those patients over years, sometimes additional events continue to happen. And to see if we can get better at this, we are creating new stent designs, new stent technology. So for example, one of the things we thought about, that polymer which we put on the stent to provide the drug to that area is kind of unnecessary. It's nothing but a plastic. Why don't we just put the plastic on one side, not the all side, make it very, very thin, and make it biodegradable. So by 3 months or 6 months, all there is left is a very thin metallic strut stent, and that hopefully will help us heal those arteries better. Then somebody says, well, hold on, maybe we can make stents without polymer completely. So these are some of the new stents I'm showing you guys, which you may come across in your clinical practice. So one of the innovative idea was to create laser drill holes, and the drug molecule is actually pushed inside those holes, and the drug actually exudes after that, and that allows for prevention of restenosis. This is a very clear, smart idea where stents with use of nanotechnology are now covered with polysine F. Polysine F is like, you know how we have Teflon on a cookware? This is pretty much like that. It makes it thrombo-resistant, so none of the thrombus forms there. But the real excitement is about Absorb. Absorb is a stent which is kind of completely bioabsorbable. And this is now currently approved in the US. We are very excited about that. And it basically allows for the drug to elute at 3 months, and then slowly and gradually over the next 2 years, the stent is completely gone. So by the time a 50-year-old guy who comes to our cath lab, we put in a stent, by the time he's 52, his artery is brand new and completely normal without any stent. This is what a typical procedure looks like. This is an image of a right coronary artery. This patient had a large ischemic defect, a lot of angina, and once we took him to the cath lab, we cross the lesion with a wire, do a balloon to open up the lesion, and then put in a stent, and this is what it looks like. It takes me 2 minutes to show this and maybe 30 seconds to do it. So that's one of our typical stent procedure. We have some advances. One of them is IVUS. We can actually look at inside of a blood vessel. So you can actually see this is the lumen of the blood vessel. There's a little bit of atherosclerosis at the bottom. Then we also have something called OCT. This really gives us high resolution pictures. You can actually see a previously deployed stent, and this is neoatherosclerosis or scar tissue inside that metallic stent. This is a photograph or OCT of an absorbed treated artery where you can see there is obviously no stent, and more importantly, there is no scar tissue atherosclerosis. This is a promise of the new bioabsorbable technology, which we hope to exploit more over time. We can also learn about the physiology. You know, it's one thing to have a blockage. Other thing is to find out how much does it affect the pressure in the blood flow beyond the lesion. So we have developed this technique called FFR, which allows us to validate the severity of stenosis. So if something is intermediate looking, 50, 60, 70%, we'll drop this wire. It will allow us to tell if there is actually ischemia because of the lesion. And if there is, then we'll go ahead and fix that. What about those vessels which are horrible and calcified and they just have tons of calcium because all this plaque eventually gets calcified? Well, we have diamond birds, which are called Diamondback, as well as rotablator birds, which allows us to, it's literally burying. I mean, I'm burying those vessels, it goes zzz inside those coronary arteries and sloughs off, it microvascularizes all the products there. So that usually is used in conjunction. We would first do that and then put in a stent. So you'll hardly ever see a patient who just had a bird. They would usually have a stent eventually. The other devices. So thrombus aspiration, as Dr. Kunupali said, if the patient is having a STEMI and there's a large amount of clot, we can actually suck those clot out. We actually have an embolic protection like a little umbrella, which prevents any clot from going more downstream. Then there are newer technologies, really fancy stuff. Like, for example, one of the things we are doing here at Methodist is what is called CTO. So these are people who have completely blocked arteries, sometimes for 10, 20 years. They have failed bypasses. What we do is we actually go through the wall and come back. So we literally create a bypass around the blockage with a catheter. So this is something we do in the cath lab. Not only that, we can go from the right side of the heart to the left side of the heart. We can actually use those collateral channels to rewire and open up an entire artery. So these are some of the new technologies we are using. Antithrombotic therapy, which is aspirin, should be given to all patients on the day of PCI. We are more and more using bivalirudin or angiomax, but heparin and Lovenox is also used. What about 2B3 inhibitors? I don't know if any of you guys have been here for the last 10 years, you would know Riopro, Tirofiban, Integrilin. We used to use that a lot because it reduced ischemic complications, especially after coronary stenting. However, the studies have failed to show upstream administration. And we also know that as an adjunctive therapy, it can be used as individualized patients. Somebody has a large amount of clot or a thrombus, you will continue to give them 2B3A. What about antiplatelets? Dr. Kleiman mentioned a little bit about it. this is your take-home message, going to be on all the board exams. Somebody who has an ACS and gets a drug-eluting stent, they have to get 12 months of DAPT. No questions asked. If you get a DES, in the absence of ACS, somebody who had an abnormal stress test and comes to the cath lab, we put in a stent, then 6 months is all you need. But ACS, irrespective of the stent type, you require 1 year of DAPT. So non-ACS patients, for bare metal stents is 4 weeks, for DS is 6 months. But again, re-emphasize, if somebody is ACS, please make sure those patients get 12 months of DAPT. Thank you very much.